Good evening, my dear colleagues. We will talk today about an important topic for every cardiologist: how to read coronary angiography. First, we will start with a brief history of the evolution of nowadays coronary angiography. This actually back to 1651 by Dr. William Harvey, who tried to catheterize the inferior vena cava of a cadaver during his experiments to understand the circulatory system. This followed in France by Dr. Chavot and Marie at 1863 when they introduced a catheter via the internal jugular vein reaching the right ventricle and right atrium, and they recorded for the first time the intracardiac pressure waves. Then a brief trial by Dr. Werner Forssmann at 1929 in Germany. For the first time in living human, Dr. Forssmann performed a cut down in his own left arm cubital vein, and he introduced a urethral catheter about 16 centimeters into his venous system reaching the heart shadow, and then he did this chest x-ray. Actually, he was awarded Nobel Prize at 1956 for his initiatives. Then for the first time we have this picture of the first selective coronary angiography of the right coronary artery at 1956 by Dr. Mason Sons at USA, when his catheter used for supravalvular aortic injection accidentally slipped and went into the right coronary artery, and giving this picture of selective angiography of the coronaries for the first time. Then the marvelous evolution of nowadays percutaneous coronary intervention was by Dr. Andrea Grunzing at 1977 Germany. For the first time he invented the balloon system, and he did for the first time balloon angioplasty for this patient. He was 38 at that time and presenting with crescendo angina, and he underwent balloon angioplasty for approximate LED lesion. This patient is still alive. So back to our talk. Does interpretation of coronary angiography need special skills? Actually, it is simply an eye exercise. The more you see, the more quick you can identify coronary anatomy and comment on the lesion. So at the start, you should be familiar with coronary anatomy. So at this figure, we see the left main coronary artery that gives rise to the left anterior descending artery, which run on the surface of the heart in the interventricular groove from cranial to caudal direction. Then the left circumflex run in the atrioventricular groove and turn around the heart to run the back of the heart in the atrioventricular groove also. On the other hand, the right coronary artery arises from the right cranial sinus, run on the front of the surface of the heart, then turn along the right heart margin to the back of the heart in the AV groove and give off a descending branch run in the posterior interventricular septal groove, which is the posterior descending artery. This form actually two rings, a vertical ring which is composed of the left anterior descending artery meeting the posterior descending branch of the right coronary artery, and a horizontal ring formed by the left circumflex artery meeting the posterior lateral branch of the right coronary artery. So again, we have two orthogonal plane. The first one is the vertical one, which aligned with the interventricular septum, along which the LED running from cranial to caudal position, and another horizontal plane along which the left circumflex artery run in the AB groove. To understand this orientation, this is an important step on understanding all the coronary angiography view coming in the coming few slides. So at the cath lab we have the X-ray machine. This is the source of X-ray, and here is the image receiver. So we have two directions of movement of the X-ray tube, right and left direction, and cranial and caudal direction. Actually, all the coronary angiography view made by combination of both movement. So if we move the tower to the left and then cranial, this view will called left cranial view. So this picture giving us an insight about the different angiographic view. We have at first the right caudal and the epicaudal view. We are looking at the heart from the leg of the patient, and these views are aligned with the horizontal plane of the AV groove. So during the epicaudal or right caudal view, you will find the circumflex artery running vertical on the image, as we will see in the coming slides. For simplification, both views have similar picture in the coronary angio. So we will deal with epicaudal view and right caudal view as a one view, just for simplification. The second orientation is epicranial and right cranial view. Here we are looking to the heart from the head side of the patient. These views are aligned more with the interventricular septal groove. So at these views we will find the LED running along the picture from the cranial to caudal direction. The third view is the left cranial view. It is a quite little bit similar to the epicranial and right cranial view, but at this view the LED will be running on the middle of the picture. And the fourth view is the left caudal view. This view actually we are looking at the heart from the leg side of the patient, and it gives like a cut section on the base of the heart, like the great vessel view in the echo, and you will find the origin of the left anterior descending artery and left circumflex artery as coming in the following slides. So as I told before, for simplification we will deal with the epicaudal and right caudal view as same orientation, and right epicranial view also similar orientation, then left cranial and left caudal view. The lateral view we'll talk about it later on. It is pathognomonic, so it will need a little illustration. So we have in this picture some views. We are looking from the direction of the head of the patient called cranial views, and we have views on the opposite side called caudal views. The caudal views are good views for assessment of the circumflex artery and left main, while the cranial views are excellent views for assessment of the middle and the distal segment of LED. So how to differentiate all these views? We have a classic teaching method which depend on anatomical markers like the diaphragm. If you see the diaphragm at the pictures, this means that we are looking from the head side of the patient or the cranial side of the patient. So when I see the diaphragm, most probably it is cranial view. Then we will look at the caster shaft. When the caster is seen on the left side of the coronary picture, this means it is a right cranial or epicranial view, and the opposite is true. So at this picture we have the diaphragm, so it is cranial view. We have the catheter on the left side, so it is right cranial or epicranial view. So how to differentiate between right and epicranial? Simply, when we are seeing the vertebral column and the ribs are horizontal, this means we are looking anteroposteriorly, so it is anteroposterior view. When we are seeing just the rib and its direction is oblique, this is right view. So as this picture, when we apply these rules, we have the diaphragm, so we are cranial, the caster on the left side, so we are right or epicranial view. Then we look and we appreciate that here is the vertebral column and the ribs are horizontal, so it is epicranial view. So which is the left circumflex and which is the LAD? As we discussed before, the cranial views are aligned more with the interventricular septum of the heart, so the longitudinal vessel that run along the picture is the LAD, and the other one is the circumflex. And as a rule, the LCX follow the view, which means when the view is cranial, the LCX is the upper one. When we are dealing with a caudal view, so the LCX will be the lower one. Here in this picture we are dealing with epicranial view, so a cranial view means that the LCX is the upper one, as in this picture. Another example, here we can see the diaphragm, so this is a caudal view. The caster is on the left, so it is right cranial or right caudal or epicaudal view. We can see the vertebral column and the ribs are oblique, so this is a right caudal view. And as we mentioned before, that the circumflex follow the view, so this view is caudal, so circumflex is the lower vessel seen here. And as we discussed before, the caudal views are aligned more with the atrioventricular groove of the heart, so the vessels that seen running along the picture is the circumflex one. Or simple alternative, just memorize this four and you will identify it directly without this all anatomical mark. As we told before, for simplification, the right and the epicaudal view we are dealing as one view. This is picture of this view. Just memorize this shape, and when you see it, it is either epicaudal or right caudal view. How come this view? As we discussed, at the caudal orientation, we are aligned with the atrioventricular groove, so the circumflex will be along the view as we see here. For more orientation about the heart chambers, here is the LAD running interventricular septum, separating the right ventricle from left ventricle, and here is the circumflex running in the AV groove, separating the left atrium from the left ventricle. The second orientation is the right and epicranial views. As we told before, for simplification, we are dealing as similar orientation. So we are looking from the cranial side of the patient, we are aligned with the interventricular septal groove. So the vessels that run along the picture is the LED running in the interventricular septum. And for more orientation about the chamber, we see here the LED running in the interventricular septal groove, separating the right ventricle from the left ventricle, and circumflex vessel running in the EV groove, separating the left atrium from the left ventricle. So when you see this view with this orientation, just memorize this picture. It is pathognomonic one. When you see it, it is either epicaudal, it is either epicranial or right cranial view. And as we discussed before, when we are dealing with cranial view, the circumflex follows the view, so the upper one is circumflex. The third orientation is the left cranial view. We are looking also from cranial orientation, so the vessels that run along the picture along the interventricular septum is the LED one, and the other one running on the lateral surface of the heart is the circumflex one. Again, with chamber orientation, LED running in the interventricular septal groove, separating the right ventricle from left ventricle, and the circumflex vessel running in the AV groove, separating the left atrium from the left ventricle. As we told before, the cranial views give an excellent view of the mid and distal segment of LED. The last important view from the four orientations is the left caudal view. We are looking to the base of the heart from the caudal orientation. So this is the base of the heart, and here is the left main coronary artery branching into the left anterior descending artery, which is running on the front surface of the heart, and circumflex artery running on the lateral surface of the heart. There is with chamber orientation, LED running interventricular septal groove, separating right ventricle from left ventricle, and circumflex artery running in the AV groove, separating the left atrium from left ventricle. This picture is quite similar to spider, so it is called spider view. The last view is the lateral view. We are looking at the heart from the side of the patient. So the sternum is in the front, diaphragm blue. It is quite similar to a lateral X-ray with the LED running on the surface of the heart in the interventricular septal groove, and the LCX running on the lateral surface of the heart between the left atrium and left ventricle in the AV groove. And the branches that arise from the LED at this view running towards the lateral surface is what is called diagonal branches. So to sum up, just memorize this picture, and when you see a view you will identify it directly from the image in your brain rather than the algorithm of anatomical markers that we have discussed before. So when you see this orientation, this either right caudal or epicaudal view, and when you see this orientation, this epicranial or right cranial view, when you see this pathognomonic orientation, it is left cranial view. This one is spider view. The right coronary is much easier. It is single artery that branch to terminal branches distally, unlike the left main, which branch early. So we have the right coronary artery running on the right surface of the heart, then on the back of the heart to give the posterolateral branches that run in the AV groove, and the posterior descending arteries that run along the posterior interventricular septum on the AV groove. In this orientation we are looking from the left side of the patient, from the patient head, left cranial view. So we are seeing the opposite copula of diaphragm. This view is very important on assessment of proximal and mid segment of right coronary artery. The second view is the epicranial view. We are looking anteroposteriorly. So as we see here, the vertebral column is seen in the middle of the view, and this view actually straightens the distal segment of RCA and its terminal branches, posterolateral and PTA branches. So it is valuable view for assessment of the distal segment of RCA and its the terminal branches, posterolateral and PTA branches. As we discussed before, the posterolateral branch is running in the AV groove, so it is run as a continuation of the right coronary artery in a C-shaped manner, and the one that leave the RCA and descend downward in the posterior interventricular septum is the PTA1. The third common view is lateral view. As we discussed before, the lateral view is looks similar to lateral X-ray, with the sternum seen anteriorly and diaphragm below. And here we are seeing the right coronary artery running on the right surface of the heart, then back surface of the heart to give it terminal branches, posterolateral branch in the AV groove, and the posterior descending artery in the posterior EV groove. This view is valuable when we are troubled, which is the posterolateral branch, which is the PTA branch, or which is the RV branch. At this view, the RV branch running anteriorly on the to supply the right ventricle, so it is the anterior one, and the terminal branch that run horizontal on the AV groove is the posterolateral one, while the descending one is the posterior descending artery. Here is example of what we discussed. In this picture we are seeing the opposite copula of diaphragm, so it is a left cranial view. We can appreciate a lesion in the mid segment of right coronary artery here, and the branch that goes in continuation with the RCA is the posterolateral branch, while the descending one is the posterior descending artery branch. And on this view we see the vertebral column at the middle of the view with the rib horizontal, so we are in AB cranial orientation, and the terminal branches, posterolateral and PTA branches, taking a good segment of this view. The final view is the lateral view. Here is the sternum, and here is the diaphragm, and here is the RCA, proximal mid segment and distal segment, with its terminal branch, the posterolateral branch, and the AV groove, and the posterior descending artery descending on the posterior interventricular septum. This view is valuable for almost every segment in the RCA, the proximal, mid, and distal branching system. So coming to the next question, how to name coronary segments. Starting from the left system, the left main artery giving rise to the left anterior descending artery and left circumflex artery. The left anterior descending artery, or LAD, composed of three segments: proximal segments that end when the LAD gives the first septal or first diagonal branch, and the second segment end when the LAD bend downward, and the third one is the continuation of LAD till the apex of the heart. Regarding the circumflex, composed of two segments, proximal and distal segment. Proximal segment extend till the circumflex give its first obtuse marginal branch. Regarding the right coronary artery, it is composed of three segments named as regard of the bends of the right coronary artery. So the proximal segment end when the RCA give it the first bend here. Then there's the mid segment that end at the second bend of the RCA, and the horizontal distal segment is the distal segment 1. Regarding the branches of each artery, as we discussed, the left main give rise to LAD and LCX. On some percent of patient, there might be a third branch running on the lateral surface of the heart called ramus intermedius. Regarding the LAD, it gives branches that run on the lateral surface of the heart called the diagonal branches, and multiple branches running in the septum called septal branches. Circumflex give rise to obtuse marginal branches, and the RCA give rise to sinus node branch and conal branches supply the base of the heart and the RVOT. So sometimes selective cannulation of the conal branch might cause ventricular arrhythmia. Then the RCA give a branch that supplies the right ventricle called the RV branch, and another branch that run along the lower border of the heart called the marginal branch, and the famous terminal branches, posterolateral branch on the AV groove and posterior descending artery on the posterior interventricular septum. At this point, which is called the crux of the heart, the RCA gave rise to the AV nodal branch. That's why we might see some patient coming with inferior S-segment elevation, myocardial infarction, and heart block due to occlusion of the RCA proximal to this branch. Another question: how to nominate the dominant artery? Simply, the dominant artery is the artery that supplies the posterior septum, which is supplied by the posterior descending artery. In about 85% of patients, this branch arises from the right coronary artery, so we called it right dominant circulation. In about 8% of patients, this branch comes from the terminal part of circumflex artery, and we called it left dominant circulation. In about 7% of patients, both circumflex and RCA give small posterior descending branches, and we call this situation a codominant circulation. So how to it by angiography? The best view to appreciate which vessel is dominant is the left cranial view of the left system. In this example, this is the left main, and here is the LED running along the picture in the interventricular septum, and here is the circumflex artery. We look if we see a branch that crosses the midline and run on the posterior surface of the septum, or in another word, posterior descending artery. This means that the left circumflex is dominant, which is the situation in this patient. We can see this branch that crosses the middle line and descend in the posterior interventricular groove. So simply, when we take this view from the left system and see this situation, as in this case we see the posterior descending artery arising from circumflex, we can call it dominant left circulation or dominant circumflex. The second question, or the next question: how to assess the lesion severity? It is a simple exercise, just comparing the lesion with the reference, proximal and distal reference. Simply at this view, we see this right coronary artery, and here is the mid segment. We can see a lesion that is by eyeball about 90%. For grading the lesion severity, a lesion between 25% and 49% is called mild, 50 to 69% is called moderate, and a lesion more than 70% is called severe, and more than 90% is called subtotal occlusion, and 100% lesion is either acute, as in cases of myocardial infarction, or long-standing, which is called chronic total occlusion. An important thing when assess a lesion is to take two orthogonal or perpendicular view to assess the lesion, because we have what is called the eccentric lesion, as in this example. When we are looking for this lesion from the healthy side, you might underestimate the lesion, while if you take another orthogonal or perpendicular view, you can appreciate the lesion. Here is an example. This is two orientation of the same patient. We can appreciate that the lesion looks more tight when we take another view. So to be more accurate in assessing the severity of coronary lesion, there is a little bit more objective method, which is called quantitative coronary angiography, or QCA. It is present in almost all cath lab. It depends on a simple idea, which is calibration of the image. Here is the catheter. Our catheter, if it is a 6 French catheter, that means it is about 2 millimeter. And the first step is to calibrate the catheter by putting a marker on it. Then we determine the area of interest, and then automatically it gives us assessment of the lesion severity in comparison with the proximal and distal reference using this calculation. Another more physiological and reliable method is assessment of the fractional flow reserve, or what is called FFR. Simply, it is convert the equation or utilizing the equation that flow depend on the pressure and resistance. When we neglect the resistance by giving a vasodilator drug like adenosine, in this situation the flow can be replaced by pressure, or in a simple word, flow equal pressure. So measuring the proximal pressure, which is measured from the catheter, the engaged catheter, and the distal pressure using a certain pressure wire, plotting them against each other after elimination of resistance by giving adenosine, can give us a ratio of the pressure distal and proximal to the lesion. And this number, if it is below 0.8, this is a significant lesion. In this example, it is about 0.71, so it is significant lesion. So I don't have FFR in my cath lab. How accurate is my angiographic evaluation of the lesion? Data from the FAME trial give us insight about this question. A lesion 50 to 70%, which is a moderate lesion, by angiography, only 35% become significant when we have FFR measurement of such lesion. On the other hand, a lesion more than 70 to 90% by angiography is in 80% of cases significant also by FFR. So most cath lab adopt this threshold for identifying significant lesion more than 70%. By this method, you are 80% of cases concordant with physiological assessment with FFR. This number rise or this accuracy rise to 96% if the lesion is more than 90% by angiography. Another method for assessment of lesion severity, especially on the left main trunk, is putting your eye inside the vessel using intravascular imaging, either with ultrasound, IVUS, or optical tomography, OCT. The next step is how to assess coronary flow. We hear this term, the TIMI flow. So what is TIMI at first? TIMI stands for thrombolysis in myocardial infarction, which is a series of trials predating the primary PCI era, where they assess the success of thrombolytic therapy by doing angiography after giving fibrinolytic therapy and degrading the flow according to the success of this therapy. It is still adopted for assessment of coronary flow even and after the primary PCI era, where if we have total occlusion of the vessel with no contrast at all passing through, this is called TIMI zero flow. If we have a little bit penetration of dye but not reaching the distal vessel, this is called TIMI 1 flow. If we have full penetration of dye till the end of the vessel but sluggish or delayed in comparison with, for example, if we are assessing LED in comparison with circumflex, this is TIMI 2 flow. If the flow is rapid from proximal to distal, which is the normal one, it is TIMI 3 flow. And here is example of the different grades of view. Here is, as we discussed before, this view is the right caudal view. Here is the left main, and here is the circumflex artery. And this is the LED showing proximal total thrombotic occlusion with no trickling of dye. So this is TIMI zero flow. In this picture there is a similar view, right caudal view, but with a slight trickling of dye, but not reaching beyond the mid segment of the vessel, so it is might be TIMI. In this picture is right cranial view, the LED running along the picture, and the dye reach the end of the vessel, but as we can see in comparison with circumflex, it runs very slowly, so it is TIMI 2 flow, and we can appreciate the cause, which is proximal, almost subtotal occlusion of the LED. And here is the same patient after stenting this lesion, the flow improved, and we can call it TIMI 3 flow. We talk about the flow in the epicardial coronaries, but what about all this meshwork of microcirculation? Actually, this microcirculation is what really matters for the perfusion of myocardium. If you open the epicardial vessel and doesn't take on mind this microcirculation, you might end with scarred myocardium. Grading system. Grade 0, there is no plush at all. Grade 1, there is a minimal plush. Grade 2, there is a moderate plush, but if we have like a left system picture and we are assessing the plush in the LED in comparison with LCX, if they are similar, it is grade 3. If it is a little bit little on the LED territory, for example, than the LCX in comparison, we give it grade 2. Then we have a special type of lesion that may mandate 13 type of treatment, so it is important to happen in this lesion. First one is thrombotic lesion. If we have a primary PCI patient, we might hear the term of heavy thrombus burden. Heavy thrombus burden is also assessed by TIMI thrombus scale. TIMI stands also for thrombolysis myocardial infarction, because it is described in this series of fibrinolytic trials. We have 5 grades of thrombus burden. The most important to memorize is grade 4 and 5, which mean a heavy thrombus burden. Grade 5, we have total occlusion of the vessel, as we see here, even after wiring of the vessel. This is called TIMI 5 thrombus grade. If we have flow distally, but we see a filling defect that is in its greatest dimension, more than double the vessel diameter, it is grade 4 thrombus burden. In these grades 4 and 5, which is called a heavy thrombus burden grade, we have a room for certain treatment like glycoprotein 2b3a or thrombus aspiration, which shows benefit in this grade of thrombus only, not on the low grade thrombus. But what happens if we neglect this and just crush the thrombus and put a stent here? Actually, this thrombus will not dissolve. It will fragment and go to the microcirculation, and we will end with a beautiful epicardial coronary vessel, but with no microcirculation. And if we fold such patient, we will find a scar mostly in the territory of this vessel. Another type of lesion is a calcified lesion. Also, coronary angiography is not the best method for assessment of calcification. It has a low sensitivity of about 50 to 60% in comparison with intravascular imaging. But if we see this picture in such patient in angiography, we put in mind that this patient might need special type of treatment, especially if we have this shadow before even the contrast filled the artery, as we appreciate here, and here also in the proximal LAD and the left main segment. Here is a spider view or left caudal view, and here is lateral view. So if we have calcification that is seen in 2 orthogonal views, that mean it is a little bit might be exceeding 180 degree of the vessel, or what is called circumferential calcification. This might mandate certain type of treatment, as we mentioned before, like rotablation in this case. And here without dye we can see the coronary artery, which is the LAD in this patient, seen without any contrast due to calcification, because calcium is like a bone. We can see it on X-ray without dye. Third type of lesions is in-stent lesion. We can see the stent before the dye enters the artery, like a meshwork. In case of this type of lesion, we might have an extra option, which is a drug-coated balloon, instead of putting another layer of metal inside this metal layer. Then we have myocardial bridge. This happens when a segment of the coronary artery in this patient, it is left anterior descending artery in this right cranial view. As we can appreciate here, we have this segment of the mid-LAD compressed with each heart contraction. That means that instead of as in normal populations that the artery run epicardial on the surface of the heart, it goes deep in the myocardium and get trapped by a muscle segment, that causes squeezing of artery with heartbeat. It is important to differentiate between this bridge and another atherosclerotic lesion, for example, because the method of treatment is totally different. In this patient might benefit from drugs like calcium channel blocker, but if still symptomatic, he might need surgical deroofing of this muscle segment. But if this patient underwent just a stent on this segment, on 99% this stent will become occluded due to a mechanical deformation of the stent. So in such patient we must know this shape of the bridge and know that stenting in this case do harm. Lastly, we have what is called the chronic total occlusion lesion. For more appreciation of the length and the shape and the course of the totally occluded segment, we do what is called dual injection. We are engaging in this picture both right coronary artery and left coronary artery. This slightly this view showing injection firstly on the donor vessel or the RCA that give retrograde septal branches to the distal segment of LAD. Then we inject dye on the culprit vessel or the CTO vessel, so we have appreciation of the length of the total occluded segment, just to be familiar if we see such picture. This actually mandate different treatment strategies, special wires, microcaster, and indeed expertise. We have the famous syntax score, which is described from a large trial comparing surgical treatment versus treatment with first generation Taxus drug-eluting stent in patients with multi-vessel disease or left main disease, and they get like a scoring system to give a cutoff point when PCI is preferred, when cabbage is preferred. They have a website that you can enter the data and get the score, or you might download it from the Google Play using this application. You have to fulfill a certain question. First you will find this picture asking which is the dominant circulation. Then he will ask you to choose the diseased segment of coronaries, either proximal, distal, or mid segments, branches, diagonal, or septals. Then he will ask you to describe the lesion. Is it CTO? Is it bifurcation? Is it calcified? Is it thrombotic? And etc. Finally, you will get a score. In case of left main disease, if this score more than or equal 33, that means that surgical treatment have a mortality benefit and a better outcome than PCI, and it should be the treatment strategy of choice if patient is accepting. In case you have a score between 23 and 32, you have either option, but still cabbage might have more benefit regarding less need for revascularization and less target lesion failure. If the score is low between 0 and 22, you have both option equal results. In case of 3-vessel disease, if we have a low score 0 to 22, we have both options are valid, PCI or cabbage, but a score intermediate or high, which is more than 22, in these cases cabbage have mortality benefit and a better outcome in comparison with PCI, and it should be the treatment strategy of choice if the patient is accepting. Even in the low syntax score, patient with multivessel disease have worse outcome with PCI due to higher rate of in-stent restenosis in diabetic patient, and so even with low score, still cabbage has the upper hand in diabetic patients. As we see here, these scores should be familiar with, so you can calculate it in case of left main or multivessel disease to get more data about the risk-benefit ratio of each treatment strategy for better patient counseling. Then we will have a quick overview of the basic tools. In this picture we have Dr. Melvin Jotkin, who gave us the Jotkin casters that we use in everyday practice in 1968. Before this era, the caster was shaped by the operator using a heat source. But thanks to Dr. Jotkin, we have the pre-shaped caster used for left and right coronary artery that we are using in daily. Just simple overview. Here we have a guiding caster that is C-shaped, called extra backup caster or EBU catheter, and this view is right cranial view, so we have this radio opaque thing which is a guide wire across the vessel. We have something inflated with two dots which is a balloon. We can predict the size of balloon from the number of radio opaque dots. Balloon 2 or more in diameter have two dots. Below the sides, like 1.5 balloon, it have only radio opaque marker on the middle of the balloon. On this picture we see a stent which is more dense, more radio opaque meshwork like we see here, and it have two radio opaque marker for accurate detection of the location of the implantation site. So finally, my take-home message is learning coronary angiography depend on practice. As we said before, it is an eye exercise, so the more you see, the more rapid you get familiar with the views, and you can find on this link a valuable book by Dr. Colombo called Tips and Tricks if you're interested more in the basics of interventional cardiology. Here is another book which is Essential Angioplasty. Also it is a good and this website of the European Association of PCI, they have what is called the fellow course that arranged during the annual conference of EuroPCR. Actually, this is a very valuable course, highly recommended for all our junior colleagues. You can have a free membership for the European Association of PCI Society, and you can access all the previous years fellow course. You will find everything about coronary angiography and the BCI from the initial steps to the advanced steps in this course. And here is another a valuable source, which is Dr. Manos Perlakis, an eminent interventional cardiologist from USA. He has an excellent book called The Manual of Percutaneous Coronary Intervention, and he is discussing this chapters of this books. You can find it on a playlist called The Manual of PCI Chapters, starting from planning to PCI to the advanced steps of PCI. And finally, thank you.